Welcome, everybody. Welcome to our webinar. I'm Dr. Chu, and I'm here today with an esteemed panel of guests, including my co-host, Dr. Bassam Kadri, who I will introduce in a moment. We're here today to learn from some profound experts, clinicians, anesthesiologists, surgeons from Italy. And these are people who are managing the COVID-19 pandemic on the front lines and who have some profound knowledge to share with us about what we may expect to be dealing with here in the United States soon. So this is an important webinar. I want to begin by, first of all, acknowledging and thanking our guests, our panelists, our clinicians from Italy for the work that they've done, the experience that they're going to share. It is a very difficult time over there. They are dealing with some tremendous conditions. And so for them to even take a small amount of time to spend with us is very important to them and to us. So I want to thank them profoundly for spending some time with us today. We do greatly appreciate it. I also want to remind our audience who is tuning in that this session is being recorded, and we will and do have the intention to be able to share this with you both as a edited session as well as the transcripts. We will provide text transcripts. I also want to mention that we really encourage questions. So for those of you who are tuning in to us via our Zoom platform, you should be able to locate the chat window, which is to the right side of your screen, and ask questions. There will be points throughout the webinar that I will do your as the audience today to convey your questions to the panelists. That will be my job. But please ask your questions through the chat windows and we'll collect them. If you're joining us on Twitter, I have a team of people in the lab who will be helping live stream some of this content on Twitter. Dr. Amy Price will be helping with that. Kati Wilkerson and Jwani Shah from the AIM Lab with the Zoom panelists today. Share your questions with us. Finally, I want to be very brief in the introductions. I want to spend most of the time with the panelists today. Before I hand off to Dr. Kadri, I want to frame the problem for you. We are very fortunate, actually Sky News did a piece today about some of the challenges facing clinicians in Italy. I'm going to actually give Mike Wyatt from the AIM Lab the screen to live stream a video that came out of the UK today that shows some of the conditions. He has a better internet connection. So I'm going to ask Mike, our digital media specialist, to play that for you. And then when we come back on the other side of the video, Bassam Kadri is going to take over and introduce us to the panelists.
They're fighting a war here and they are losing. The sheer numbers of people succumbing to the coronavirus is overwhelming every hospital in northern Italy. The staff are working flat out, trying to keep these people from deteriorating further. They're trying to stop them from dying. This isn't an intensive care unit, it's an emergency ward. The ICU is full. People have only just arrived here and they're in terrible shape. This is an absolute constant. This killer pandemic is virtually out of control. The patients are literally gasping for air. The plastic bubbles the staff struggle to communicate through attempt to equalize the air pressure in the lungs. Nobody expected this. Nobody thought they'd be treating so many so quickly. And it's not like flu. It is chronic pneumonia, and it is killing hundreds each day.
There are now 15 patients.
The doctors say they've seen nothing like it before and are warning other countries, especially the United Kingdom, that they will see it as well.
People who keep describing this as like flu. It's worse than that, no?
No, it's totally another thing. I think it's most pneumonia than flu. Mm-hmm. Because most people get pneumonia. And as I said before, it's a very severe pneumonia. And so it's a massive strength for every health system, because we see every day 50 to 60 patients who come to our emergency department with pneumonia, and most of them are so severe they need very high FiO2 of oxygen. And so we have to reorganize our emergency room and our hospital in 3 levels of intensity, as you saw.
This is the main hospital in Bergamo in Lombardy province. It's one of the most advanced hospitals in Europe. But it's the most hard-hit of all the hospitals in Italy. The town is the center of the epidemic here. This isn't a ward, this is a waiting room. Wherever you go, people are on gurneys, in corridors, in meeting rooms, they're everywhere. All the medical staff urge other nations to see what's happening and lock their nations down right now or face this.
What I would suggest is just shut down to stop all the outbreak and not come in this kind of situation that is very, very difficult to manage.
Can I ask you personally what it's been like?
I never felt so stressed in my life. I'm an intensivist, and I'm quite used to, intense moment and choices, and people are critical and will die without any, treatment, and you make the difference. But when you arrive at this point, you realize that you are not enough, and maybe we are 100 anesthetists here. We are doing our best, but maybe it's not enough.
We are performing the test for the nasal swab to detect coronavirus.
The problem facing health services across the world is that when the infection curve goes up, it rockets. And all the resources, all the testing, all the supplies are used up instantly. Multiple hospitals all at once.
What's staggering is that Italy is doing a lot of testing. Thousands upon thousands are being tested. So far, about 4,000, the numbers keep changing, have actually completely recovered. The crucial point is that about the same number are dying. They're sort of neck and neck. And it seems you either live and recover or you die. Something nobody expected.
Bergamo wanted us to see this to show what a catastrophic emergency nobody has experienced before looks like. Here they're calling it the apocalypse. And this is what it looks like. And their message to us is simple. Get ready. Stuart Ramsey, Sky News, Bergamo, Italy.
So with that sobering piece, I think I'm just going to dive into the meat of the topic. First, again, I want to thank all the attendees who are attending this webinar, and I also want to thank our panelists who are taking time from their busy schedule to share their experience. just a little bit of ground rules. The target audience for this webinar are anesthesiologists, intensivists, perioperative staff, and the rationale for doing this webinar was primarily to see if they were going to give themselves advice on what they would have done differently 2 weeks ago, what would they share? And this is unprecedented times. The way the mechanics of this will work is that we will go through each topic and try to provide time for Q&A at the end of each topic. The topics are hospital capacity management, workforce capacity and safety, triage and risk stratification, ethical dilemmas, the clinical management of COVID-19 patients, of which we're going to spend the most amount of time on, the clinical management of emergent non-COVID-19 patients, the anesthetic management in the OR, and discharge planning for those who are blessed enough to make it through these difficult times. One last note is, the intent of this is to share stories and experiences, and though this is not, prospective randomized studies, there is still a lot of value. The evidence is still being developed, so please make note of this when assessing the content of this lecture. So the first section is on hospital capacity management. Dr. Vanni Agnoletti will be speaking about his section, and I'll yield the floor to him. Vanni, just be sure to unmute your microphone when you speak.
Thank you, Bassam. So we work in a hospital that have 450 beds. Our ICU beds are 17, and we have 18 operating rooms. We started with COVID, this war, the 2nd of March, and we are in the middle. We are not in the front line, but we are close to the front. Usually, we admitted 300 of patients each day in the emergency department. Today, we see 20 patients per day in the emergency department. Half of these patients are COVID positive. So the number of patients is not so high, but all these patients arrives to our hospital. If you consider the number, the total number, today we have 80 patients in our hospital COVID. And the ratio of ICU patient is 10%. So today we have 8 patients COVID in ICU. But this is a war, and we have received other patients from other cities. So we have 15 patients in ICU. Now we have 4 patients out of ICU because we treated them and we want to send them back home. The average number of ventilator days are 15-20, and the length of stay in ICU is probably 20 days. We started with only one room with negative pressure, and we use not artificial but natural pressure because outside is cold, and we didn't know how to create a negative pressure. So we opened the window, and like a temperature gradient, the temperature, so the air can follow the flow from inside to outside. We didn't know what to do. And today, believe me, is not a problem, the negative pressure. We don't know how many patients are getting discharged every day because we don't have enough number. Probably 1 or 2 per day. I'm talking about COVID positive. We didn't know what to do at the beginning, so we decided to create 5 more ICU beds far from the normal ICU. So we have 17 beds for COVID patient and 5 beds, ICU beds for no COVID patient. we reduced the surgical activity of 80%. We are a trauma, level 1 trauma center, and now, believe me, there are no trauma at all. So we can use these 5 beds for all the city. It's not simple, but we are trying to manage. If I look at me in the back, 2 weeks ago, what is important for me now, for us now, is that we don't have a plan for discharging the patient. We thought to put the patient inside of the hospital, and today we don't know how to put the patient outside of the hospital. We didn't think about the post-ICU. We are trying to create sub-intensive beds, but believe me, it's not easy. We were not prepared to think about the post-COVID patient. Thank you.
So
we are, Bassam, okay. The star where we live, and Bergamo is high in the big red circle.
Okay. So, Dr. Chu, I think this is a good time to start getting the questions from the audience. I'll hand it over to you, Larry.
Thank you. So we are getting some questions in from the audience. I also encourage more of you to ask questions. I also remind you to, when you are sending your questions, make sure to select all panelists and attendees when you're typing in your questions. So here's a question that comes from one of our audience members. What characteristics do you use to determine what operating room cases are elective versus urgent, or to do during this period, pandemic period? Many elective cases are still happening right now in the United States. How do you make that decision?
Yep. We decided to reduce on elective cases and to give priority to oncologic patients. It's not easy. And we try to stay in a period of time of 30 days. So we try to give operation to patient in 30 days. For all the surgeons, every day, only one operating room can work from 8 in the morning to 8 in the afternoon.
I see. And then going back to the period of time before you had the severe influx of patients until today, did you find the number of elective cases was, how were they being handled?
Can you see again? I didn't hear.
How are you handling elective cases?
Now?
Yeah, now and in the immediate period before.
Okay, before there was a scheduling cases for week and for month. So we have to respect all the surgeons have a scheduled operating room. For example, general surgery have, for elective cases, they can use operating room 12 hours a day for 5 days a week, except one day that they can work only 6 hours. Now, in 1 week, they have only 12 hours for surgical procedures. And it's the same for all the for example, for ENT surgery, they have for 1 week only 1 day of 12 hours. So each specialty, all specialties have only 12 hours per week. Monday, for example, general surgery. Tuesday, for example, ENT surgery. Wednesday, breast surgery, and so on.
Another question. do you have a dedicated team for managing intubations or airways for COVID-19 patients? And how do you manage with a shortage of PPE?
It's a good question. We don't have a dedicated team for COVID intubation. If you need to intubate a patient, every part of my staff, every anesthesiologist can intubate the patient. We follow the guidelines of our hospital, and we don't have a specific. And there's my colleague that after will speak about that. And I don't remember the second question.
How are you dealing with the shortage of face masks and personal protective equipment?
You know,
we are trying to, yeah, there's a doctor, and after we'll speak about that, Alessandro Circelli. But now I can say that we're trying to follow the rules, but it's not easy. Be prepared to manage the fact that you don't have PPI.
Sam, I heard you chime in. Do you want to move on to the presentation? Take some more questions?
Absolutely. I think these are wonderful questions. I think the next it's actually a perfect segue to the next section of which we're addressing workforce capacity and safety. And I think contextualizing the questions to each topic, hopefully we'll be able to get through all of them. And at the very end, just as a reminder for everybody, there's going to be an open Q&A for the entire panelists. So the next speaker is Dr. Circelli, who's going to be talking specifically about the last question of safety and workforce capacity. So Dr. Circelli.
Hi everyone, everybody. I'm sorry. I'll talk about workforce capacity and safety, and I show how we use PPE. Next one, please. The first case is COVID development in family health teams in emergency department, but in a few weeks conquered the whole Italian territory. A lot of health care workers were involved in COVID-19. 3 days ago, more than 2,600 patients are COVID-19 positive. It's about 8.3% of the total. To contrast this war, we have to stop, as my colleagues has just said, all the elective surgery, all the elective procedures like colonoscopy, angiography, and also ambulatory outpatients. We continue only emergency surgery, emergency procedures like thrombectomy for stroke, angioembolization for aneurysm or exsanguinating patient, PTCA, etc., and cancer patients. This can reduce virus transmission, but can permit a large number of nurses and medical staff that are free for COVID wards and new wards that are creating in this situation. This is our personal protective equipment we use. This is me. It's a surgical mask when we stay in the isolated wards or ICU away from the patient more than 1 meter. When we have to perform operation or invasive procedures, we use eye liver protection masks, FFP2 or FFP3. Surgical gauze is okay if it's liquid repellent, 2 pair of nitrile glues, surgical cap, of course, For invasive procedures or tracheal intubation, also ECMO cannulation, or also non-invasive ventilation that can generate aerosol, we use eye protective suit. And of course, surgical boot covers and important vision shield to protect our eyes. Different dress code. This is three different dress codes because Our Lady want to be different, but are safe. This is the Italian style. Today, we have a PCR test only when we are symptomatic. This is not true in all the Italian region because health system is have a federal organization, and so it's different from in my region from other region. When we feeling sick, we have to stay or come back to home with a fever more than 37.5 degrees, 99.5 Fahrenheit, and cough. There is a law, an Italian law in promulgating the 3.8 that say you have to go back. You can stay at home, but quarantine is recommended. Running out the personal protective equipment is a risk, a real risk. It's an important problem because now all the world demand PPE, and most of the production is in China and India. In our country, a lot of industry start to change production towards masks, gloves, but we need some weeks to see this kind of change. There is not a unique solution. Civil protection assistant try to manage supplies, but it's not simple. We have to remember that we have to use only necessary equipment, and we also ask anyone who can help us. For example, private dentistry clinic that in this moment are closed, they gave us some masks. What advice I have to gave to myself 2 weeks ago? 3 weeks ago, we were looking for ECMO circuit. Really, we found them, but only few people really require extracorporeal oxygenation. Nobody know how many, maybe 2-3% of ICU patients. This is not a so big number. It's important that it's time and resources consuming, and lymphopenia is a problem that you have to pay attention. What we need is mechanical ventilators. So, take home message. The problem is mechanical ventilators, and the problem in protecting the protectors. Protect yourself to continue to cure. Good luck to everyone. Thank you very much.
Thank you. Larry, I'll yield the floor to you for collecting questions.
Okay, great. So we do have some. So going back to the previous question, how are you protecting healthcare workers, so doctors, nurses, and technologists from exposure during this pandemic period? And given the high percentage of patients that are coming in for testing at your hospital for COVID-19, are the majority of people wearing PPE prophylactically at all times?
Yeah, this time a lot of the normal people and outpatient wear normal surgical mask. It's standard in our city, but I think all in the Italian territory.
So our lab has recently looked up some numbers and found that about 8% of healthcare, 8% of the cases of COVID-19 in Italy are from healthcare workers, and that in cases where PPE is becoming scarce, that the number of healthcare workers are getting infected actually is increasing. I'm going to try to get Dr. Amy Price, who did the research, to give me that exact number. But I think that number was 8.3% of total cases. So with that number in mind, when you ran out of PPE, did you find you were able to have workarounds to that, either sanitizing or reusing? And if so, what were your workarounds?
It's a problem because no one at this moment in the war, I think, have the solution. You have to check for the solution, resource, ask to friends, ask to private clinic that at this moment are closed, ask to dentistry, Protezione Civile, that is the most important institution in our country, have problem at this moment. So I think it's not a simple workaround.
All right, Bassam, would this be a good time to move on to the next section?
Yeah, I think so. Let's. This section, we're going to be discussing many of the ethical dilemmas and challenges that they're facing. Dr. Emanuele Russo will be speaking about this section, so I'll yield the floor to Dr. Russo.
Okay, hi everybody. Okay, first question is very hot topics. In Italy, there's an active debate about it. As Dr. Ciccelli already told you, in Italy we have central department of the health and 20 different district departments, one for each region. And as the outbreak is not the same in the different region, we have different decision by the local government. Because, of course, if we should leave in quarantine all the asymptomatic people, it should be better. Because now it's clear that the main source of the outbreak of the infection is asymptomatic people. COVID disease is asymptomatic in half of the cases. And but in some region, if we leave in quarantine all the asymptomatic but infected member of the staff, the health system is in danger of collapsing. So I think that there's no an answer, but the answer is in the number of the infected people for each hospital or region. Okay, question number 2 and 3, I think we have the same answer. On the 6th of March, the Italian Society for Intensive Care, Anesthesia and Pain Medicine has published some guidelines, very interesting, because the COVID disease is considered as disaster medicine, okay? We are not used to reason in terms of disaster medicine. And disaster medicine means that there is an imbalance between resourcing and needs. And so the priority is for patients who are most likely to survive. And so the answer to question number 3 is we give priority to patients who are most likely to survive. And the answer at question number 2 is the same. I think that an healthcare provider maybe has a good chance to survive because he's not old, and if he works, I think he is in good health. Okay, so I give him priority if he has good chance to survive. Okay, number 4, we don't have an ethics team. We have an ethics committee, but it doesn't mind about this question. We had 2 important meetings last year with all the members of the staff, doctor and nurses. It was very, very important because in Italy, the medical guilty could be even a crime. And so we learn to distinguish between ethics and law. And I think those meetings was very important for us, and we will do some more again. Okay. Number 5, in Italy, intensive care, palliative care, and anesthesiology is the same master specialization. So avoiding respiratory stress for every death is our first goal. And for Italian rules, we are used to give sedative to all the patients suffering, and even if giving some drugs could shorten the life, but avoiding suffer, the first goal is avoiding suffering. Okay, this is clear for all the patients, COVID or non-COVID. How are you managing family visits? Unfortunately, we have a national law that not allowed at all family visit, even in the end of life scenario. This is the opposite what we do usually, and I think that is a source of emotional distress, very important for all the physicians. And so far, we haven't had any death in our intensive care, but all the physicians that had a death in the department told us that one of the worst experience is people living alone. We are not used to this, and I don't like it at all. Okay. Body are managed as the non-COVID. The same treatment at all, nothing different. Okay. What advice I can give you? So far, as Dr. Agnoletti told you, we are very close to the front line, but so far we have not imbalance between needs and resources. I think that the only advice I can give you is to improve all the resources. It means mechanical ventilator, beds, and even drugs. We have now close to have problem with anesthetic drugs. And so I think that the advice is improving all the resource, and if we have not imbalance, we have not ethical challenges. Okay. Thank you. I'm here for some question.
Yeah, I'll ask one question and then I'll hand it to Dr. Chu. A question that keeps coming up is about the limitation of events and the prioritization of that. I'm sure the ethics of managing that, can you just walk us through the process of how you prioritize your vents, and then are you running into vent supply issues? And then after this, Larry, I'll let you go on with the next questions.
Okay. It's not yet happened, okay? And this is the main question. Of course, the priority is for the patient who has the main chance. In guidelines, there's an important question. The rules first come, first served is not valid, okay? If we have finished the ventilator and we have a patient ventilated with less chance that a new one arriving, we will okay, by the Italian recommendation, actually, I think that the new patient with more chance needs the ventilator, and we will ceiling the care to the old one, maybe with less chance than the new one.
Larry, do you have other questions that you collected? Very challenging issues.
Yeah, we do have questions coming in. So a couple questions pertinent to this topic on ethical challenges. How are you ensuring patients with disabilities are not discriminated against?
Okay, I think that there's not discrimination, but maybe and maybe they have less chance to survive to the disease. Okay, this is the question, not discrimination. Okay.
Can you talk a little bit about how you're dealing with that right now, managing that, or how you make decisions around that?
Okay. It's not the same for the same. If he has the chance to survive, I will give him mechanical ventilation and ICU care. If he has less chance to survive, I don't give him. And as I told before you, disability is not the main question, it's chance of survive. It's just this. Okay.
All right, moving on to another question. Are patients that are into cardiac arrest from respiratory complaints pre-hospital worked, or has the decision been made to not work on these patients?
Okay, we usually have a briefing every day, and we have a discussion about all the cases. Okay, we usually maybe one of an anesthesiologist, an intensivist, visit the patient, and after we talk with the colleagues, and we is in the cases not easy, we have a collegial decision.
Okay, and then do we have time for one more, Bassam, or should we move on?
No, if you have a good question, by all means, go ahead. This is a very difficult topic.
Okay, one last question. Was there discussion about ethics for the ambulance before the patients arrived to the hospital?
Okay, yes. Outside the hospital, there's a protocol, okay? But till now, in our region, we have no this problem, okay? The ambulance bring the patient to the emergency room, and then he can be he can receive a new evaluation. In other region, they have a protocol, okay, for the out of hospital patients. We don't have till now because so far we don't have this problem of imbalance.
Okay, I'll hand back to you, Bassam. Okay,
thank you. This next section, we're going to be spending more time on the clinical management of COVID-19 patients. Our speaker would be Dr. Emiliano Gambarini, and I'll yield the floor to you, Emiliano.
Hello to everyone. And so we are speaking about clinical management of COVID-19 patient, and we will starting by saying something about the clinical diagnosis. And so diagnostic criteria are usually the clinical history, which is very common in this patient. We have symptoms starting about 1 week before the patient get very sick and ask for hospitalization. And usually initial symptoms are cough and fever. And these period of 1 week is quite repeated in patient we have seen. So as the diagnostic criteria, we use pharyngeal swamp, but we have seen a lot of false negative results, and so probably it's better perform a deep sample, in a deep respiratory sample, like bronchoalveolar lavage. As I have dialed this slide yesterday evening, I haven't seen yet the new guidelines for COVID-19 treatment, in which was published on intensive care medicine, I think today, where they say that it's better to perform a normal sample, bronchial sample, better than bronchoalveolar lavage, perhaps because it's easier to get some aerosolized and get contaminated with bronchoalveolar lavage. And so even if the patient is intubated, we always, and if they have a CT scan that is very similar to the COVID-19, we always repeat the swamp by a deep sample by the trachea and bronchi, even if the pharyngeal swamp is negative, because this large amount of false negatives. And so about CT scan, I think that maybe Professor Venerino Polete can say something more, because he's a great expert about imaging and lung imaging. But I think that there are two patterns which are very common. The first one is the ground glass, especially a peripheral ground glass. And then there is another form which is a little bit, which have a more consolidative aspect, and it looks like even more something about an organizing pneumonia. And we found that the sickest patient have this last pattern, the organizing pneumonia, and looking for his history, we have found that this kind of pattern always is expressed in patients who have been dyspnoic and fighting for breathing for long days. And so this can be an aspect about the diagnosis. So speaking about ventilation management, I have to say something about non-invasive ventilation. And so we prefer using CPAP, and especially we use helmet CPAP, because it's easier to get to limitate air leak by the interface where you use the CPAP and with the non-invasive ventilation. And if we can, we have only one room with negative pressure, and we have two single boxes for which is a single box with only one patient, and all the other ICU is an open space, as an open space organization. So we prefer to use non-invasive ventilation in single rooms, in the single boxes, to limitate spreading of aerosol and so. Why CPAP, helmet CPAP, we think is better than non-BPAP with mask, and so is to limitate air leaks and to get and even to get an easier way to understand if the patient is going well with non-invasive ventilation, because I think that it's quite difficult to synchronize with the BPAP, to synchronize a sick patient as COVID-19 patients are with a BPAP. And so probably the best non-invasive approach is the CPAP, and then you have to be very fast to convert into invasive ventilation if the CPAP doesn't get your target, which are an oxygen saturation over 95 and respiratory rate over 25. when we intubate the patient, we keep on with lung protective strategy. So can we go? We can go. I want to show this video. If it works. If not, I can try to share my screen if you want.
Mike, can you, I'm going to stop sharing the screen, and if you could share yours, that would be great.
Okay, I will share my screen.
Okay, go ahead.
Just a moment. Just I'm coming. And so I want to show you a video which is which demonstrates how important it is to have good flow on the CPAP to get to be sure to give something good for patients. And I'm starting to select, and I try to share what I want to show you.
Okay.
And so as you can see, to gain an high flow, we are using two systems connected together. It's a mechanical CPAP system. It's quite old and out of production, but we use with the satisfaction, connected with high flow oxygen by the mechanical ventilator. Together, we connect with an Ypsilon in a white tube to the humidifier, and then we get to the helmet. As you can see, we are monitoring the pressure inside the helmet with a normal transducer, which is not filled by water, but is filled only with air, so that we can realize if the pressure is really continuous, and if it's not, this means that we need to increase our flow. So I come back to the presentation. No. Okay. So I need to come back to the presentation. Okay. Sorry for this delay, but so when we go to invasive ventilation, we always need to set a lung protective ventilation strategy. Prone position is highly indicated if you can reach a PaO2 FiO2 ratio over 100 with a high PEEP, 15 or more PEEP, and maybe in some patients, especially in obese patients, we need to monitor esophageal pressure to try to discriminate between problems in compliance of the lung or problem in compliance with the chest wall. So speaking about lung protective ventilation, the principle of lung protective ventilation are using a low tidal volume, and so we use a tidal volume of 6 millimeter per kilo of body weight, taking into account that you need to think about ideal body weight and not real body weight, because we have a lot of obese patients, and especially young patients and women are obese, and this is an epidemiological feature that we can take into account. We need to set the ventilator to keep a plateau pressure below 30 centimeters of water, a driving pressure between 15, respiratory rate to get pH of 7.25, allowing an hypercarbia, which can be considered a permissive hypercarbia. We titrate PEEP to get PaO2 FiO2 ratio over 150, and we titrate FiO2 to gain PaO2 of 55-18. And so prone position is another thing that can be very useful. And I try to share again my video to show you something.
Okay.
Are you seeing the video?
Not yet.
Not yet, okay, just a moment. No, this is not
No, yes.
This is not what I want to show you. Sorry for these difficulties, but I'm sharing the wrong one. So I can't do it, and so maybe it's better to go on.
You want to move on? Okay.
Yeah, we move on because so let's go back to the presentation. Okay, I can see the presentation anymore. So another thing, so we are proning patient. Go back a little bit. We are proning patient, and we need to schedule the prone position because it's a quite hard workload for all the staff. And so we are proning and deproning patient at the changes of the suite of the shift of nurses. So usually we deprone patient in the morning, and then we prone other patient again in the afternoon shift, and usually we get depronation and other pronation in the other shift changes at evening shift, evening change shift. And we have since now pronate about 9 patients, and 2 of them were pronated 4 times. And so it's a workload, quite important workload. So going back a little bit, for hemodynamic management, obviously you need to have a fluid sparing strategy. We need to use sometimes vasopressor, even because some of the patients are blockade, are paralyzed, and so we need deep sedation. We have seen that we have problem with SCVO2 because it's quite difficult to interpret in this patient, and some patients develop pump failure. About SCVO2, we have seen strange things that we found very high levels of SCVO2 in the early stages of the illness, until almost 90 of SCVO2, even in patients who are hypoxemic and with high PEEP. And usually this SCVO2 get normal when the patient is a little bit better. So SCVO2 is working on the opposite way as it's done in other patients, and it is strange things in other for this patient. So, speaking about medications, about antivirals and hydroxychloroquine, tocilizumab, and corticosteroid, Professor Venerino Poletti, we spoke about it, and we are using ketamine as sedative drugs because of the less hemodynamic impairment we can have with this sedative, and speaking about other medication, which we think it's important, is some specific issue about artificial nutrition. Speaking about ketamine, we think that ketamine has great advantages as a sedative drug because is even a bronchodilation effect. We can reduce the need for fluids and vasopressor because it's known that it impairs hemodynamics less than other hypnotic and other sedative agents. Remember that if you use continuous infusion of ketamine and 1 to 4 milligram per kilo for minutes, sorry, there is a refuse in the slide. It's 1 to 4 milligrams and not microgram per kilo per hour. Sorry for this problem. Remember not to use BIS with the ketamine because it can be detected the deepness of anesthesia with BIS using ketamine. And about nutritional target, we use a quite not so high caloric intake because we have hypoxemic patient and we have often problem with hypercarbia, and so we prefer enteral nutrition, enteral products with an inverted ratio from lipids and carbohydrates, and we target at 2 grams per kilo DA of proteins. We know that is a quite high target. European Artificial Nutrition Association indicates as a target 1.3, but while American guidelines are a little bit more prone to consider higher protein intake, I think that the incidence of obesity in this patient and the quantity of corticosteroid we give and neuromuscular blockers make the problem of losing muscular tone, and so we decided to target our nutritional intake to 2 grams per kilo DS of proteins, and omega-3 are considered as a supplementation. So other problem is we are seeing some ventilatory associated pneumonia about 7 to 10 days. We are seeing a lot of central venous catheter related bloodstream infection. Probably this is due to the fact that it's quite hard to protect themselves and protect even the patient by cross transmission. And this is a very important issue, I think, because it's quite difficult to use all the attention we use for the patient when before the COVID pandemic. Another thing that is quite strange not strange, but we need to take note of this, is that immunosuppressed patients rarely are affected by severe forms. Thus, assuming the fact that probably the most part of this illness is due to the immunitary response and not by the viral activity, maybe. Another thing that we can say is that there is a quite high incidence of severe myocarditis leading even to cardiac arrest and to severe pump failure. And we have seen 2 patients in over 21 we treated, so probably the incidence is about 10% of severe patients treated in the ICU. Thank you very much.
What I'm actually going to do is I'm going to, Dr. Poletti's got the second section of the clinical management. And there's a lot of good questions that are being asked. So I'm going to have him continue and then open the floor to questions to both doctors. So Dr. Poletti.
Hey.
Hi, may you hear me?
Yes, we
Yes.
could hear you.
Good morning. It's a very unpleasant and difficult time, but you know, we are fighting a very difficult battle against the virus. May I have the first slide? No, yes, this is about treatment. We use it's good. We use inhibitors of viral replication, lopinavir and ritonavir. They are antiprotease drugs usually used in HIV patients for HIV virus. And there is an ongoing trial, not yet really started in Italy, or started only in a few centers, with remdesivir. Is a nucleotide analog used in Ebola virus and in other RNA viruses, and I think it could be very promising. The important strategy is when you need to use some clues indicating that this pneumonia may be sustained by hyperimmune reaction, and in fact, patients have a two-step profile. Their fever, myalgia, asthenia for 7-10 days, and a subset of them develop respiratory failure 7-10 days later, probably when acquired immunity start to work. And in this context, and also we know that from the laboratory point of view, there is an increase of inflammatory cytokines, mainly interleukin-6, and the use of tocilizumab is a monoclonal antibody against interleukin-6 receptor used in rheumatoid arthritis, was used in China and now in Italy, and we experience with this drug and with preliminary good data. There is an ongoing trial, observational trial, and a phase 2 trial started 1 day ago with this drug. So, and the other big point is, do you use steroids or not? We have some data that are against the use of steroids, but these data are not so strong. And in this context, when we have a rapidly progressive respiratory failure, we tend to use steroids, 30 milligrams twice a day of methylprednisolone. So this is all about treatment strategy from the clinical point of view.
Okay, so Dr. Chu, I'm going to hand the floor back to you. There's a lot of great questions, so if you want to go ahead.
Yeah, we've had a vibrant discussion during both excellent talks. Thank you both. And I will just begin because we have so many questions. I'll start by asking a question that is on the top of everyone's mind, which is, what have you noticed in general for your patients about the timeline between the onset of symptoms and the need for mechanical ventilation?
So the time that is between the starting of symptoms and the appearance of acute respiratory failure, is it correct?
Yes.
I think that we have, the time is about 10 days after the onset of fever, dry cough, myalgia, and asthenia. So we have a period in which respiratory failure is not present, and it appears later.
Do you use a symptom severity score or other metric for determining how critical a patient is in order to help with triage or to allocate resources?
I will discuss later with 2 or 3 slides this question, so I will answer later.
All right. Another question that's been on the top of a lot of people's minds: have you been ventilating more than one patient using the same ventilator? Many people have seen this described, but have no experience.
So I can answer, Venerino, if you want.
Yes, yes, it's up to you.
So we are hearing something about this in the last days. We know that during SARS pandemics, in some setting, someone did it. I think that you can do it with dedicated respiratory circuit, which is not so simple to provide it, but you can do it. But I think that it can be respiratory circuit, which is not. It can be only a problem when you have no more resources. And so, as Emanuele said before, fortunately, we have not this problem yet. We hear that someone is thinking about this, but I have some problem with this, because you have to choose patients who are quite similar in his soma, because I think it's quite difficult to think of ventilating patient of 50 kilograms or 100 kilograms in the same way. And probably if you have to do it, the best option is pressure control ventilation, which is probably less harmful than volume control ventilation if you have two patients ventilated with the same ventilator. But I hope never to do it.
Okay, next question. How are you handling emergent airway management? Specifically, how are you pre-oxygenating given the limitations on flow and concerns over mask leaking? We've had significantly decreased safe apnea times given changes to our airway protocols.
So I think that Giovanni Scognamiglio will speak about this topic later, but we use pre-oxygenation with high flow oxygen, or with a face mask with a reservoir, and we use rapid sequence intubation. But I think that Giovanni will speak about this topic later.
What are the criteria you have used for ECMO candidacy? And how many patients have you placed on ECMO, and how many have survived?
So we haven't placed the patient on ECMO yet. We treat 21 patients. We consider the ECMO for 2 of them, but after the 4th cycle of pronation, their PaO2 VO2 ratio now is over 100 without proning anymore, and with the PEEP level below 15. So I think that you have to consider ECMO for this patient, but you have to be sure to have done everything you can do with your ventilation strategy before to perform it. Another issue for ECMO is veno-arterial ECMO in case of severe myocarditis or in case of cardiac arrest, which is a topic. And I know in another hospital in Italy, they have 2 patients of VA ECMO for this problem of pump failure due to myocarditis and not VV ECMO. Because I think that those lungs are not so difficult to ventilate, and probably this illness will go a little bit better with mechanical ventilation, having a little bit of taking a little bit of time and do everything you can do with mechanical ventilation. But maybe Alessandro Circelli can say something more about ECMO.
Okay, I'm going to end with two questions, each on subspecialty anesthesia. The first about obstetric patients. What is your PPE, personal protective equipment protocol for obstetric patients, specifically those receiving labor epidurals, versus having to convert to general anesthesia during C-section?
So I think that it's better than Vania Agnoletti will answer this question. If the conversion from anesthesia for local regional anesthesia to general anesthesia is an emergent indication, we use the same issue we use for in-hospital emergency system. So in case of suspected or a certain case of COVID-19, we use all the protection to perform tracheal intubation.
Okay, and then I know that we have more to go, so we'll wrap up now and ask other questions later. But this last question for pediatric patients, is it true that pediatric patients are less affected by COVID-19? Are you routinely testing all pediatric patients, even asymptomatic patients?
No, we are not testing pediatric patients routinely. And it's true that they are significantly less affected, and the disease is quite mild and can be more an enteritis instead of a pulmonary disease. And in fact, the problem for children is that the virus is more frequently found in the feces instead of the nasal swab. So they can be distributors or spread problem, but they are not routinely affected. They are not heavily affected and routinely screened for SARS-CoV-2 so far.
Okay, Bassam, I'll hand it back to you.
Okay, the next section is clinical management of non-COVID-19 patients, obviously that are emergent. You know, it is a hospital. There are other patients who may be unfortunately experiencing a stroke or a heart attack. So Dr. Luca Assaloni, as one of the surgeons, who will be sharing his experience with this.
Okay. Did you hear me? It's fine?
Yes.
Yes, thank you. So I have not prepared slides, but I have sent to Bassam a couple of drafts of 2 articles, 2 editorials that they will be very soon published on World Journal of Emergency Surgery regarding 2 topics. One topic is how to manage an epidemic like this by the system, by the hospital system, the health system. And the second one is which advices we can have in order to treat patients when they go to theater for different situation that is not COVID-19. So according to the first idea, the first topic is the main, and Bassam can share those drafts already to everybody that won't know that, won't read that, is that what we are facing actually is like a mass casualty that every day is medium mass casualty that brings some patient to our hospital. So it's not like the usual mass casualty where you have just one hit, but every day you have an hit, and you increase the number of patients that are coming to the hospital. What you are looking in your ICU is just the top of the iceberg. And a huge part of the effort of the health system is to manage the patient before reaching there, because they entering in the casualty. You have to make the diagnosis, trying to divide patients that are dirty with COVID-1 and those that are not. And actually, you need some wards where you have to put patient waiting for the test or waiting to be placed in the COVID-1 area, ICU, or less complicated patient with the COVID, if they are COVID-19 positive. So actually, you are facing really, and everybody that will be involved in a mass casualty like this, he has to plan for an everyday mass casualty that will last for at least, regarding to what we know, a couple of months, with the peak that it will be in the middle of that. So for sure, you will have a lot of effort to be put on the entrance of the patient and of the exit of the patient. Actually, our main, the vast majority of our hospital in Italy, they don't have a mass casualty plan. So what the hospital, the only advice that I can give to somebody else is to review the mass casualty plan of every hospital in order to afford a medium mass casualty that they will last for at least 2 months. Second thing is regarding what we do for the other surgical procedure that they have to go to theater. The good news is that we are seeing that all the other emergency, they are reducing. For example, in Italy, we have stopped the people inside in the house, so we are not seeing any more trauma, because the vast majority of our trauma, they are from vehicle collision. So in this case, for example, we have seen that our system is less under stress for the usual situation. Other thing that we can do is just to cancel all the elective procedure, as Vanni was telling before, that they are not urgent or emergent. What you can do is to avoid to do oncologic surgeries that they will go to deteriorate in 1 month. So most probably you need to do those surgeries, and we are doing that actually. How to manage the patient? For sure, if you are aware that the patient is positive or he has a disease, for example, is coming from the ICU, from the COVID area ICU, you should manage the patient, and you need to bring him or her to theater for another surgery. You need absolutely to take all the third level protection for the people involved in that surgery. What to do for patients that they are coming for an emergency situation and they are not symptomatic, or for those elective patients that they have an oncologic problem and you need to be to operate on them. In that case, according to me and according to what we have done now, we are taking for the anesthetist and the nurse that is helping the anesthetist the third level protection, personal protection level. For the other one, when the patient is ventilated and the other one, they are not in danger and they don't have a risk of contamination, we just take the usual protection that we take usually in any surgery, in any emergency surgery in theater. I don't know if I answer to the question that you did to me. To answer to the 8th question, what what advice I wish you could have given to myself 2 weeks ago to manage emergent non-COVID patient. Actually, according to the first topic, we were not prepared to the mass casualty. This is the problem. So actually, what is my advice is for hospitals that they should afford this kind of problem is to really to review the mass casualty protocol. Second one, instead, is how to manage the patient in theater. For sure, even there we don't have a particular protocol for those patients. We need, or those hospitals that they will afford this kind of patient, they should look after to have a protocol in theater. Maybe one idea can be to have theater only for COVID patient, COVID-19 patient, and other one for suspect or for a symptomatic patient. Thank you very much.
Okay, we have some questions.
Yes, we do. We have quite a few questions coming in. So one question is regarding scheduling and therefore canceling of elective surgeries. Looking back at your experience now, what would that window look like? Several, would you be looking to cancel elective surgeries several weeks out? Are you looking at several months out? What does that window look like?
Actually, according to what is my experience in this moment, you should consider at least a couple of months before. I mean, we have not canceled the patient. We keep the patient on the list, and we tell them that they should postpone the surgery for at least a couple of months.
All right, the next question. For the elective or urgent procedures you're doing, are you using full PPE given the high rate of community transmissions and the fact that there's aerosolization of the virus during airway management?
Not for all the patients, actually. Only for those patients that they are positive. I tried to tell you what has happened yesterday. we have a patient with a discitis and with an abscess in a psoas, in the right psoas muscle. In a lady that he has developed a sepsis due to this. We have tried to make just a drainage without opening her, and the drainage was not enough. She's still on fever. So yesterday we planned for a surgery. The patient is in hospital still since 15 days ago. Actually, 2 days ago, and she was in a medical department, and 2 days ago they decided that because she has fever to test her. And when we reached theater, the result of the test was still not out. So we decided, because it was not so emergent, the situation, in order to drain the abscess, and she can wait at least a couple of days to wait for the test. Today the test was negative, so most probably we are going to make a procedure tomorrow. I don't know if I answered to your question with this example.
Right. So I think the question that many of us have is that there is a shortage of PPE, and therefore we are wondering if the use of full PPE is always done if you do not know what the status is of the patient.
No, we do. We wear full PPE only for patients that are positive and they are sick for COVID-19. We are just taking the usual protection for theater for all the other patients.
Okay, I'll move on to the next question. Are you continuing with transplant surgeries?
We are not in a transplant hospital, but I know that my colleagues, for example, in Bologna nearby, they do.
What would the panelists advise to approach all elective, urgent, and emergent cases if a patient in non-tested and even asymptomatic patients? Would you advise us to approach all elective, emergent, and urgent cases in non-tested and even asymptomatic patients as if they were COVID-19 positive?
I
will preface this by saying that in the United States, our testing currently is probably not as accessible. We are not able to run as many tests as other countries.
Actually, first of all, regarding testing, being involved in the screening of the patient, in at least 20% of the patient that they have a CT scan positive is test negative. So even doing a diffuse testing for a symptomatic patient, I don't think that there is a rationale to do that. Instead, to decide which patient have to go to theater and which kind of protection you should use, first of all. Second thing is that actually is the question that you are doing now is just the reverse of the question of before. We don't have enough protection for all the patient, for the personnel, for doing all the patients that are coming to our theater in this moment. So The only thing to reduce the risk is to reduce the number of surgery that we are doing, to take protection for the patients that are truly and for sure positive, and to do our best for those patients that should have emergent surgery or oncologic urgent surgery, elective surgery.
Thank you. Next question. Are cardiac surgeries being performed? And if so, which types of cardiac surgery?
I don't have data. I don't have data because actually our hospital is not an hospital with a that does heart surgery. According to what I know, even for what the other colleagues they are telling me, they try to reduce as much as possible the surgery. They do only those surgeries that they are for sure absolutely you should do absolutely because the patient is not for that surgery. But really, we are not an hospital with a heart surgery available, so I cannot tell you if in which size the cardiac surgery is still done in Italy.
Okay, maybe one last time for one last question. How have you, if you know, you may not know how this is done, but how have you managed cleaning of the rooms in the ED or the CT scanner or the operating room after a PUI is passed through? And what about unknown asymptomatic patients?
Okay, actually, normally the disease is a droplet and contact. The risk is due to droplet and contact. So the usual cleaning of the theater, normally it should be enough to clean everything on the contact and on the area that they were at least in theater, that most probably they were contaminated. So a deep cleaning of the theater should be enough. On the CT scan, actually, I don't know if there is any protocol for taking any particular I mean, if we take any particular precaution in order to clean the CT scan, but I will try to have an idea tomorrow.
All right, thank you so much. Back to you, Bassam.
All right, just to explain to everyone, we have two sections left. One is the anesthetic management of patients in the operating room.
Hello, hi everybody, what's up?
And then the second is going to be discharge planning. So Dr. Giovanni, the session is yours.
Airway management, and I will tell you about it. Please, next. Next. Okay. I hereby reported the guidelines by the Italian Society of Anesthesiology and Intensive Care, as we have to minimize the exposure and the aerosolization of the virus. We have to consider early intubation. Of course, when dealing with the airway of a positive COVID patient, you have to wear your PPE. As Alessandro earlier stated, the PPEs are high protection certified masks with N95 or PP3, Foxtrot Papa 3, a face shield, a waterproof gown, and 2 pairs of gloves. Always remember to wear 2 pairs of gloves because every time you touch a contaminated surface, you have to take off the outer layer. So it is very important. If you have a negative pressure room, intubation should take place there. If not, if it is not available, just shut down the door and don't let unnecessary people inside the room. As for the technique, the rapid sequence intubation is quite advisable because you have to minimize the droplets in the air in the environment. If you have a video laryngoscopy, it should be used because it limits your proximity to the airway. Of course, put a bacterial filter on your circuit or on any oxygenation interface. How do we pre-oxygenate these patients? A high flow oxygen should be avoided above 10 liters because above 10 liters there is aerosolization. So keep a reservoir mask with a flow oxygen below 10 liters, let the patient breathe spontaneously and then go on. As I said earlier, don't allow non-critical staff in the room. Do not bag the patient, never bag mask the patient because it can be very dangerous for you. And only the most qualified and skilled physician should perform the intubation. After intubating the patient, avoid disconnect the circuit. If you have to, always remember to clamp the endotracheal tube, stand by your vent, and after disconnect the circuit. After the surgery, don't bring your PPE outside the room because it could be kind of dangerous. Somebody asked earlier about obstetrics. Well, if the patient has a respiratory impairment, I think it's advisable to go with the tube. The tube is not a big deal, so intubate the patient. If the patient has not pulmonary impairment, you can try a central block like epidural or spinal. Next. As for the equipment, always keep in mind to have your PPE always on. Prepare all the equipment you will need on a trolley, a bacterial filter on every interface, and this is very important, a closed suctioning circuit. Actually, you won't have to suction your patient because this patient have very little secretion. So this will not be necessary, but if you have to, make sure you have a closed circuit, a closed suctioning circuit. As for the technique, as stated earlier, modified rapid sequence intubation. Awake intubation is not advisable because it can take time and you have to be kind of skilled with the fibroscopy. Avoid back mask ventilation and above all, wait until your cuff is on to ventilate. Go on. Next. Okay, drugs. Emiliano stated earlier that many patients have hemodynamic derangement. We don't know why yet. This might be due to viral myocarditis. So we choose to use the ketamine, which has a minor hemodynamic impact. Also consider that many patients have a lot of comorbidities, they are obese, so ketamine can be the right hypnotic drug. As neuromuscular blockers, we use suxametonium or rocuronium. Use a higher dose because you have to ensure a optimal relaxation to intubate your patient in less time as possible and avoid him coughing. As for maintenance, we use a total endovenous anesthesia, and I would suggest you to avoid the desfuran because it has a airway irritability effect. Next, please. How do I ventilate a COVID patient? They have a very compliant lung, so they are very good PEEP responders. Set a lung protective ventilation, 6 millimeters per kilo of ideal body weight. Set a high PEEP in order to keep the alveoli open, and keep your driving pressure below 15 and your plateau pressure below 30. Set the fraction of O2 in order to reach at least 65 millimeters of mercury of content of oxygen. Don't forget, at the end of the surgery, to perform recruitment maneuvers. These are very compliant lungs, so you have to recruit them. After the surgery, I think it is advisable to refer the patient to the ICU for extubation, because they may have pulmonary impairment, bad gas exchanges, so it is advisable and quite wise to send them to the ICU for the wake-up test. Do not take off your PPE until the patient is out of the OR. And as Dr. Anzalone stated earlier, then a normal sanification can take place. Next. Okay, this is our motto. This is our motto before the curfew was declared by our government. Everything's gonna be all right. Andrà tutto bene. We're gonna pull through. Come on, we can cheer it up. Thank you very much.
Thank you so much. So I'm gonna ask one question and then hand it over to Larry. A couple of you have mentioned that there's a pretty high false negative rate in terms of the testing, and that sometimes there's it shows up on CT scan. So given that the data is showing that, at least what you said, was 50% of patients who are positive are tested negative, are you placing respirator masks and goggles and face shields for all elective intubations, even on patients who may be asymptomatic?
No. We actually, we keep a high suspicion attitude, but if the patient is not positive, we keep the normal PPE. So we do nothing different. We don't have sheets on the vent. We do not have special devices. We just act as we used to do.
So just to clarify.
Yeah, remember to keep a high suspicion, because everybody, this is a pandemic breakout. So everybody might have had contacts with positive patients, but I think that a surgical mask will be enough.
Okay, Larry, so it just, again, because for clarification, you're treating everybody as if they have it, and you're protecting, there's two aspects, is protecting the patient and then protecting the staff. So the context of the question is protecting the staff. Yeah. Are staff wearing special masks, like the,
yeah,
they are, and goggles. So that's
the FP3, okay. The FP3 masks.
Okay.
Papa 3.
Okay, so the answer to the question is all staff is wearing full protection, treating as if, even if, as if the patient may have COVID-19.
Yeah, of course.
Okay.
They have had contacts with positive patients, because this is a pandemic breakout. Even if we are not on the front line, we are quite close. And this is a great concern. I will share my experience with you. Before the curfew was declared by the government, I told my wife to go away with my baby daughter to a country house my relatives have, because, you know, it would be kind of tough to go back home at the end of the shift and kiss my baby daughter. So this is a big for our relatives.
Okay. Dr. Chu, would you, any other questions from the audience?
Yes, we do have some questions.
Okay.
With the national lockdown, how are you dealing with blood product shortages?
With? Pardon?
Have any shortages of blood?
Huh?
Any
Okay.
shortage of blood?
They are donating blood, yeah. Few, yeah, there are fewer than the past, but they are still donating. They are still donating, yeah, fewer than the past.
Was there a need to do a tracheostomy in any of your patients?
Yeah,
And
of course. We perform early tracheostomy. Actually, our average is on the 3rd day after hospitalization for the ICU patients.
And is there anything that you want to share about that
Yeah,
process?
but this is a local protocol. Of course, this is our experience.
What percentage of the hospitalized COVID-19 patients have needed the helmet CPAP or BiPAP?
Quanti? I think about 10%. 10%, yeah. If
And
we intubate them in the ICU, then we perform a tracheostomy because it is kind of easier to wean them from the vent.
Can you tell us about the non-invasive ventilation requirements and how you're managing that?
Yeah. Yeah. Actually, yeah, we put our PPE on and then we enter the room and all the nurses and the staff, the medical staff, so surgical cap, eye shield, FP3 masks, waterproof gown, and cover on their shoes.
Can you talk a little bit about how you make decisions in balancing the risk of procedures to the staff who are involved in doing the procedure compared to the diagnostic value? For instance, aerosolization of the virus during lavage.
If the procedure is needed, we don't think about the consequences. We do what's best for the patient. If we need that broncholavage, we do it, we perform it, no matter the risk for us. No fear.
Larry, can I ask a follow-up question to that? Is the lavage, given that the clinical picture for COVID-19 is pretty strong, what is the value of the lavage and what are you looking for in particular? If you could walk us through that process as to when you do it.
It is very important also for bacterial superinfections. So it can be very useful for us because they can undergo VAPs, ventilator-associated pneumonias. So a broncholavage can be quite diagnostic to start an antibiotic therapy.
So just to clarify, the clinical picture is a patient starts getting secretions, which is suggestive of a bacterial superinfection, in which you then need to speciate, and at that point you do lavage, but you're not doing lavage. Go ahead. So I just wanted to get specificity on the circumstances. So most patients are without secretions. But then you may get a patient now who's developing secretions.
Yeah, of
and
course.
At that point, you're suspecting a bacterial, like a ventilator-associated pneumonia. At that point, you do the lavage to speciate the bug, and that's when you're doing.
You got it. You got it.
Okay. Okay.
Do you have data on how many anesthesiologists have become infected, given that we are likely performing most of the invasive procedures compared to other healthcare workers?
So far, none. We are a crew of 50 anesthesiologists, and so far, no one is infected. We are kind of lucky after 2 weeks.
Do you have any idea why that might be?
Because we protect ourselves very well. We are very concerned about protection. We had time to prepare ourselves because the breakout here arrived a few days after than in Northern Italy. So we had time to prepare ourselves.
Are there other healthcare workers at your hospital that have been infected?
Yeah, 5% of the physicians working in our hospital.
But none of them are anesthesiologists?
No, none.
All right. And then one last question. Patients usually have drops in function at least 24 hours prior to decompensation. Do you see acute drops in function right before death or days preceding?
Yes, yes. This is kind of typical. Actually, they are in their bed reading the newspaper and then suddenly they have respiratory distress. This is kind of typical. So there is an immediate drop.
So it's an acute drop?
Yeah.
Okay. All right, back to you, Bassam.
Yeah, there was one more question, Giovanni, that I wanted to ask. You mentioned that your family, in a way, you sort of quarantined them there in the country.
Yeah.
Does it make, so the question that we have is, does it make sense for healthcare professionals, if they are symptomatic, to sort of go, instead of back home, but go to a hotel? Or another question is, are staff and faculty deliberately not going back or staying away from their families?
Yeah, this can be an option. In fact, a few physicians who work here have decided that this is not for everybody. I decided to send my family in the countryside because it felt much more secure. So I think I took the right decision, because now I can go home and touch everything and contaminate everything. But it's of course, this is kind of personal. It's personal. This is my opinion.
And in how much time are you planning to adopt this, I guess, personal protocol you've implemented?
Personal protocol. No, will you repeat, please?
Are you planning to do this for 1 week, 2 weeks, 1 month, 2 months?
Okay. I get you. Gotcha. Actually, I will wait for the government to retire the curfew. So when there is no curfew, I will let my family come back to Cesena.
Okay. The last section is an important section. And for those who are lucky enough to make it through, is how do we plan for discharge planning? And Dr. Costanza Martino is going to be talking about this.
Hi, thank you for the invitation. I'm an intensivist, so I will speak about something that is done from other type of doctor, because the discharge from the hospital is done from ward. But I can tell you what is doing in my hospital, because there isn't a protocol in Italy for the patient discharged from hospital. And there are currently no protocol in our hospital, for example, on specific tests. We use now clinical discharge criteria, and the clinical discharge criteria are absence of fever for 3 days before the time of discharge, significant clinical improvement, and symptoms start more than 10 days from the decision of the discharge. The negativization, the negative pharyngeal swab is not a criteria for discharge, only clinical criteria. And about the second question, does a patient need to stay in quarantine post-discharge? Yes. Yes, he had to stay in quarantine for 14 days after their discharge from the hospital. And where? Now they stay, if they are self-sustaining, if they stay at home alone, in a room, ventilated room, open window, but they have to stay alone. And if they are not so able for the self-sustenance, in our area, we live in an area called Romagna. We are organizing the possibility to have a quarantine in a hotel of the tourist coast. And what about the third question? Have you seen any readmission? Yes, we have seen. Now we don't have patient discharge from the hospital, intensive patients, only patients admitted to ward. But we have seen readmission when we discharge patient before 7 days from the beginning of symptoms. So we changed our protocol using the criteria of the 10 days. The fourth question, how are you managing any COVID patient outside of the hospital? Now, no. And about the advice, the advice is to move faster than us, the improvement of resources, of facilities for these patients, for all the steps of the pathway, sub-intensive care pathway, ward pathway, and return to home. And another advice is to not discharge patients before the 10th days to avoid readmission, because it's not yet finished the adaptive immunity stage of the this disease. Thanks.
Thank you, Dr. Martino. I'm going to open the floor for questions. So Larry, if you want to field the questions from the audience.
Okay, we're still waiting for some questions to come in. While we're waiting for questions, I'll ask one. You know, it was brought up, I think, at the beginning that one of the unforeseen issues in this pandemic was actually discharge planning. And that was something that perhaps was unanticipated in terms of, giving a lot of thought early on. What might you recommend to us here in the United States around the issue of discharge planning that we could focus on now?
You have to, per il discharge per la famiglia, per il paziente, you have to instruct very well the patients and the caregiver about this disease, these symptoms, but also how to stay in the isolation, in the quarantine. It's very important.
And
not outside, yes. You have to respect all the rules to not to go outside from this room. You have not to have meeting. It's very important. Okay, because we are thinking to bring nurses to their home and not they to be, yes, because they are not alone. It's very important to organize a different type of treatment of these patients inside their home.
How would you relate discharge planning of a patient with COVID-19 to, for instance, other communicable diseases like, for instance, tuberculosis or other, conditions? You mentioned a home nurse. Would there be things that would there be elements of discharge planning that we could plan for here that would benefit from supporting patients after discharge better, like home nursing or social work or other safety?
For nursing are very important. Yes, it's a solution.
About telemedicine?
But now we have not data because we have few patients discharged at home. We have started now the war.
And do you find that once you you are infected or have gone through an infection that you then have immunity, or you no longer can get infected?
Nobody know. We don't know. We don't know when are not infected. You have two swarm negative. It's not so sure that you are not free from this virus.
Have you any experience in telemedicine with discharge planning?
No.
Patients using telemedicine?
No, in Italy not.
Okay. All right. Well, thank you. This was very helpful. Back to you, Bassam.
Yeah, there was a few more questions. I think Dr. Circelli, if you're there, maybe a good person to answer. One was about convalescent plasma therapy. Have you implemented this sort of antibody therapy or serum?
We have not experience of plasma therapy. We have some paper from China, but unfortunately we have not experience on this.
Okay. The other question was about the anti-malarial medications, sort of Plaquenil. Have you been using these medications, and what has your experience been to date? Hello?
We start to use at dosage of 200 milligrams twice a day. and we have to see the results. I can give now the if it's an effective drugs.
Okay. Well, this session.
Go ahead.
I was going to say, again, I want to thank all the panelists and speakers. It's past 7 o'clock your time, and I know we are very gracious for you taking the time. I also want to thank all the attendees who have attended this event. This event was recorded and it will be distributed. There have been questions about the slides as well, so those will be sent out. And I want to make sure that, during these unprecedented times that, if there's a need to redo this event, we will let the audience know. And with Larry, I don't know if you have any wrap-up statements for everybody.
I want to remind our audience that the AIM Lab and Learnly, we do have our COVID-19 evidence service. So we are taking questions and we'll research those questions for the best evidence-based medicine to support your answer. So please go to our website and we'll, we have Dr. Amy Price and our research staff to try to help you get evidence-based medicine answers to your questions. We will transcribe the answers to from our experts and publish those for you in one of our evidence service documents that will be on our website, as Bassam mentioned. And we hope to do more of these webinars if you feel that this was useful, which I certainly do. I want to thank all of the doctors who participated today for your time. I know how busy you are, and I want to thank you for being so generous with your time. And the information that you've given us has been so helpful in giving us some ability to prepare now for, I think, what we will see soon here in the United States. So definitely on behalf of all of the attendees today, and what I've already read from the comments and from people who've been texting me, they are so thankful for the advice that you've given us, for your time today. We really appreciate all of the expertise shared. They're calling you heroes. They really appreciate all of your expertise, and I'm sure they will want to be in touch with you. And we hope to maintain this connection. And as Bassam mentioned, perhaps even do this again. So thank you. Thank you to our audience, and we will be in touch. Look to our website for updates.
Larry, Vanya wants to mention one thing. Yeah. Sorry for cutting you off. Go ahead, Vanya.
I want to remember to all audience that we are not losing the war, we are fighting the war. Thank you.
And I also want to remind our audience, we do have a mobile app, our COVID-19 mobile app. You can also get updates there for information. So look for all of that on our website. All right, and Bassam, I'll leave you with the last word.
No, I want to thank everybody, and thoughts and prayers to everyone around the world. And stay tuned. We will likely do a follow-up. And I want to thank everybody again. Thank you very much. Bye-bye now.